Hello, everybody, and welcome to the Brain Tumor Companion 5th Educational Zoom. Today, we are welcoming neurosurgeon Dr. Gabriel Zada from USC Brain Tumor Center. We're also welcoming Nicole, his development partner. Dr. Zada, we're so excited to have you here today. If you're going to share a little bit of your expertise with us. As you know, I am Angel. I am the founder of Brain Tumor Companion and Meningioma Companion, which is a peer-to-peer platform, a support platform, an educational platform for patients and their caregivers, as well as any of their support people. It's always my goal to bring educational opportunities like this one today to our community, and also to raise funds for research. So I give you the Zoom room today, Dr. Zada, to share with us a little bit about who you are and what you do over there at USC, as well as your presentation. We're all very excited to learn from you today.
Awesome. Thank you so much, Angel, and to the entire group here. It's a pleasure to meet all of you, and even to people who are watching the recording and I haven't met yet. So we really appreciate this opportunity. And maybe just to share about a little bit about our story, about the USC Brain Tumor Center, and how we came into relaunching our center with a focused effort on patient advocacy and care, and really trying to understand the patient journey and the caregiver journey from the beginning to as long as any kind of outcome is possible. So can I pull up some slides now, Angel? Is that okay?
Yes, absolutely.
Great. Oh, I think I need to have screen sharing enabled, please, if possible.
I thought that I had done that already. You should have access. One person, multiple participants can share. Okay, let's see. Did that help?
Yes, perfect.
Okay, perfect.
Okay, so hopefully everyone can see this.
We can.
Okay, so we're excited about this collaboration, and the reason is that we know that taking care of brain tumor patients is more than surgery and chemotherapy and radiation, and to really take good care of people with these complex, not just medical issues, but social issues, psychosocial issues, really takes a village. And so we're happy to branch out with people who share this vision with us. So I'll start with that. Our Brain Tumor Center relaunched during COVID. We decided at USC to take all the potential talent we could find across all of our campuses. And USC, for those of you who don't know, it's the largest employer in Southern California, other than the county, other than the government. It's like a huge corporation. It has multiple campuses, and we tried to find anyone who could add something in terms of value to taking care of patients or research or moving our mission forward. And what we discovered is there's a lot of people who want to help, which is really cool. So we took on the challenge of trying to be the destination site for patients with brain tumors in Southern California. And I'm happy to tell you about this. So we want to provide unsurpassed care to people from all backgrounds and destinations. And I'm really proud to say that we also are in charge of running the county hospital in Los Angeles. This is the largest safety net hospital on the West Coast. So you can imagine all the people we take care of that don't have insurance, that come with very advanced brain tumors from all over, other countries, you name it. And that's a badge of honor for us, is to try to provide the same care to people irregardless of their insurance status, socioeconomic status, education, language, any of that. And I'm happy to share how we tried to do that. Doesn't mean it hasn't been without challenges on the county side, because the resources are different, but the physicians and the team are the same. So, just a little bit about surgery and meningiomas. I'm not going to focus solely on meningiomas, but I can sit here and show images all day about how we've taken out meningiomas and treated them. But that's really not enough. It's the tip of the iceberg for a brain tumor center. We work very closely with radiation oncology to take care of higher grade meningiomas, and for me, along with the meningioma companion portion of this, I've always struggled because, as you all know very, very well, just because you don't have a brain cancer or malignancy does not mean that your brain tumor is not going to derail, prematurely end, ruin the quality of, or affect your life profoundly. And this is a major misunderstanding among even large funding sources like the NIH, that we have had to really, really work with to convince them that just because it's not considered a malignancy or it doesn't spread like a cancer, it should be treated with the same level of priority. So whether it's a meningioma, craniopharyngioma, chordoma, aggressive pituitary tumor, glioma, low-grade glioma, whatever, these are, as you all know, these are major issues for patients and their caregivers and their ability to work and be members of community to the extent that they want to be. So, this is a patient with a meningioma we couldn't treat successfully. This is the kind of thing that that really resonates with me, because most patients we can treat successfully with combination of surgery, radiation, medications, chemo, clinical trials. And this was a patient, a rare patient who we received after many, many prior treatments and offered whatever we could, but we ultimately lost this patient and succumbed to this disease. And this is a meningioma. So, I know very well how these diseases, whether they're classified as malignant, benign, whatever, can really affect patients. So what are some of the things that we really pride ourselves on in terms of clinical care delivery? Well, as I mentioned, we're the largest academic center for brain tumor care in Southern California, and that's because we have a private hospital, Keck Hospital. We have the county hospital, which is the safety net institution. So all the other county hospitals in Los Angeles refer their complex brain tumors and adjuvant care to us. We're kind of the mothership for that. And then also Children's Hospital LA, which is the largest pediatric hospital on the West Coast. So we treat a lot of patients, young and old, insured and uninsured, with brain tumors. We have a 7 Tesla MRI for clinical use, and we're really pioneering what the capabilities of that are with my colleague, Arthur Toga, who leads up this advanced imaging center. We've really focused on patient quality of life and have advanced minimally invasive brain tumor care. This is something we do a lot of, whether it's endoscopic surgery or other platforms like laser ablation, et cetera. We use a lot of fluorescence for brain tumors, and we are the first center in the United States to use blue light endoscopy for gliomas. And we feel like we're really helping to understand the capabilities of that technology. We've had Gamma Knife for 30 years, and also TrueBeam. This is something that is an integral part of our care. And in the last few years, our clinical trial portfolio has gone from about 3 to about 15 trials. And I'm going to talk a little bit about that, including 2 for meningiomas that we're very excited about. But perhaps most importantly is our team of doctors and researchers and engineers that we brought together that I mentioned, that we've really gone out and found the talent around. And so when we redesigned our brain tumor center, we wanted it to be all about the patient experience and really trying to understand what patients and caregivers go through from the beginning, the time of diagnosis. So we developed a concierge-style navigated patient experience. So that means that patients have access to a cell phone number for the Brain Tumor Center that they can text and call to get things done. This is our nurse navigator, Nancy. And then these are some of our other amazing team members who really provide exceptional care. We see patients same week. We really asked ourselves, if I had a new diagnosis of brain tumor, what would be the most important things I would want right off the bat? I'd want to see a provider that week so I don't have to wait in anxiety. I would want to be in communication with my treating team. We want people who don't just treat brain tumors as technical exercises, but really focus on the patient quality of life and what that means, and look at alternatives and fit that into the context of people's lives. Obviously, we provide telemedicine consults across the country and second opinions. And then we have a tumor board as well. But we've also brought a social worker into our brain tumor center. This is Jinsey. She is absolutely amazing. She started our monthly caregiver meeting that has now been attended really well and continues to grow. So we're really focusing on these aspects of care as well. And of course, it takes a whole group, as I mentioned. These are just some of the specialties that contribute to what we're doing in our weekly tumor board. And this is our core physician team. These are just the physicians that are dedicated to treating brain tumors here. We just brought in successfully, we recruited David Tran, who is a senior neuro-oncologist. He's an MD PhD who focuses on immunotherapy and data sciences for brain tumors. And Frances Chow is our more junior neuro-oncologist, but what a tour de force she is in terms of treating brain tumors and research, and she will be a future leader in neuro-oncology. So we're really proud of our team here. And as I mentioned, our network is really, it really lends itself to this. We're much bigger than just the Keck School. We have a comprehensive cancer center. We were one of the first in the US to have a comprehensive cancer center. My lab is in the Neurogenetic Institute. I'm going to talk about our research a little bit later, but we, on a weekly basis, take tumor samples from the OR to the lab and do a variety of different things with them that I'm really excited to share with you. Children's Hospital, School of Engineering. We work really closely with Caltech, which is awesome. I have an associate visiting professorship at Caltech and some grants with them for developing some technology to treat brain tumors, and then our imaging center. So it's a huge network. These are the official members of our brain tumor center. And you can see that they come from a variety of different backgrounds, which is really awesome. And we meet a couple times a year. We have a large retreat at the end of the year where everyone gets together and shares ideas and talks, et cetera. So what kind of progress have we made in the last year or so? Well, we recruited David Tran, which was huge for us. We have a new OR to lab pipeline that I'm going to talk about a little more. So what we're doing with that is we take live patient tumors and we continue to grow them in culture. And our goal is to have every patient tumor have an avatar in the lab that we can ultimately go back and test for drugs and obviously do genetic screening on, and then put back into animal models and test for clinical effectiveness of drugs. So that's really exciting. And what we're doing now is we're testing a whole panel of FDA approved drugs that may have effects on a variety of brain tumors. This is not just for glioblastoma, it's for really all kinds of brain tumors. We've had a significant ramp up in our NIH funding. We now have 4 or 5 members of our core center who have NIH funding, which is fantastic. I think this is really cool. We've created an advisory council for our brain tumor center, and they help to direct the future directions of our center. So this includes everything from former patients to active patients to caregivers to scientists to physicians to community advocates, people like yourselves who are invested in helping us be the best center possible and take care of patients with brain tumors. And then numerous scientific publications, et cetera. I talked about Dr. Chow. Wow, she's really an amazing, valuable member of our team, and David Tran as well. So we also wanted to be a leading site for education, and we are starting a fellowship in neuro-oncology, and this year we're graduating our 5th dedicated neuro-oncology neurosurgery fellow, Dr. Stephanie Chalk. 4 out of 5 of these fellows are going into academic brain tumor practices at universities, which is really awesome. She's going to go work in Madison, Wisconsin. Milwaukee, Wisconsin next year, which is really cool. And then as far as our resident training goes, this is our resident group, and we're ranked the #1 neurosurgery training program in Southern California and 13 overall in the US. We really focus on education with what we do. And then we really try to partner with national organizations like yourselves. This is a really good way for us to share ideas and collaborate. For the last 7 or 8 years, we've done an annual meeting with the Cleveland Clinic focusing solely on brain tumors. This alternates between Southern California and Las Vegas. And it's really a great program. And we love our colleagues at the Cleveland Clinic. We just mesh so well, and it's been a great collaboration. We've worked with the ABTA as well. We do an annual walk and run with them and a variety of other events. And so this is a great way to engage the community, as you all know as well. So finally, we really know that the future of brain tumor treatment is not going to be ablative therapy. And as a surgeon, I will be the first one to tell you this. My role in the future will probably be to do more biopsies and get tissue. So we can treat with much smarter ways than going in with cutting devices and big surgical approaches and radiation and even chemotherapies, which we know can be very successful, but can also have major effects on people and risks and et cetera, complications, and really affect quality of life. So we know that we have to outsmart these diseases. And the only way we're going to do that is research. And that's really where collaborations come in. So just to share with you a little bit about what we're doing, and you'll be able to sense my excitement here. Not only do we have a lot of NIH grants and investigator-initiated trials, we made a major push on genomics and actually looking at epigenetics. And my lab focuses on epigenetics. Sometimes the biology of the tumors is not explained by the actual DNA and the genomics. And most of you probably know this, but epigenetics is a relatively newer field that doesn't look quite at the DNA, but it looks at more which genes are expressed and turned on and off and why, rather than the genes that you were given at birth or are in a tumor. And it's become a very important field for explaining, especially benign tumors, actually. There's a major role in pituitary meningiomas for epigenetics, and in particular, something called DNA methylation. We are really focusing on immunotherapy. We just opened our CAR T cell facility this year at USC, and we have a variety of vaccine treatments in development. And then this one is really cool. My colleague, Tom Chen, who's in the middle here, is a neurosurgeon, and he's developed an intranasal drug delivery device for brain tumors. And we currently have ongoing trials for gliomas and for meningiomas of the skull base that are not treatable with surgery or radiation. And so this is a way to directly deliver drugs and chemotherapy to the tumor and brain while skipping the overall toxicity that your body would get from taking oral or IV chemotherapy and affecting the liver and the rest of the body. So this is a potential new avenue for treating brain tumors that we are really excited to pioneer here. So these are open trials. And so, especially for meningiomas and gliomas, we think this is going to be really important. We want to do much bigger things. We have some major NIH proposals that we're working on, focusing on brain metastases, gliomas, and meningiomas. We're applying for something called a P award, which is it's almost like a 5 NIH project award next year that we're getting ready for. And our goal is to get a SPORE grant designation soon. And just a little more about meningiomas. These are just in the last 2 years or so, some of the contributions that USC has made. We were involved in a trial that's wrapping up looking at blue light fluorescence with 5-ALA for meningiomas. The results of that will be coming out soon. We are the first to report a very important gene called FOXC1 in meningiomas that was published a few months ago in Neuro-Oncology Advances, and we have a lot more data coming out on this that appears to be a very important marker. We described a tumor consistency score that guides surgical therapy, looking at the firmness of tumors, and this allows a surgeon to decide whether they can use minimally invasive or bigger approaches for tumors, depending on whether the meningioma is very hard and firm or fibrous versus very soft. So as a surgeon, that's a really important thing. And then we published this cool study. This is something else I'm super excited about. We have access to a very unique database of blood spots from babies that were born in California about 40 years ago. And starting 40 years ago, every baby gets a blood spot with the potential to check their genetic information. And so if you can imagine, we don't have like 80 years of data, but we have 40 years of data, and we're able to follow thousands of babies as they become young adults. And we can find the ones who develop brain tumors. And then we can go back to their original baby blood spot and sometimes their maternal data and look at the DNA and try to figure out, are there any clues at birth that will tell us that someone is at risk for developing a brain tumor later in life? This is a very powerful data set, you can imagine. So we're just starting to dip into this for meningiomas and gliomas and other things. And so a lot of excitement there. As I mentioned, disparities in care is a really important thing. Just because we can at some places offer really quality care to patients, it doesn't mean all patients have access to that care. And so we know that there's major disparities in brain tumor care across not just the country, but even across the street from each other in different hospitals. So this is something that we've had an opportunity to study because we have the same diseases in different patient populations located half a mile from each other with the same treating physicians. But we've shown that patients present with more advanced disease, meaning larger tumors, more invasive tumors, more complex diseases, more recurrences, and some of the challenges associated with treating patients at safety net under-resourced environments. And then finally, these are just some of the members of our clinical advisory council that we rely on. Really an amazing group that continues to grow quite a bit. And we have meetings every couple months.
My job is to stop cancer and to prevent it from growing.
I use high energy ionizing radiation to treat a variety of conditions involving the brain and spine.
I'm a neurosurgeon that treats patients with brain cancer and also operates on them.
I stand by my patients and work with them from diagnosis to treatment.
We use a 7 Tesla scanner, one of the most advanced MRI scanners in the world, to push the boundaries of what we can do with scanning to look at brain tumors.
I focus on brain tumor treatment, both in the clinic, in the OR, and in the laboratory. What drives me is making a difference, a tangible difference for every patient. We're a group of clinicians, scientists, and community advocates working together to find a cure for brain tumors.
We've got the dream team, and it is a multidisciplinary team working together to make the next breakthrough in terms of the diagnosis and treatment of brain tumors.
So every time I watch this, I still get tingly. And the reason is I know these people and I know how passionate they are about this. And this is really our goal, is we want to make a dent in finding sustainable cures and remissions for these diseases. We will not stop until we're part of that or someone else does or whatever. But that is our goal. I love this quote from Jonas Salk. You guys all probably know who Jonas Salk is. He's credited with developing the polio vaccine, but the way he did that is really amazing. And it's a great story of how he had to rally a lot of people over many years until he finally got the resources to make a dent and, effectively almost cured polio in doing so. So thank you for taking this journey with us. I know we're all aligned in this mission, which is great to know without even knowing most of you. I know that we're aligned in this. And then again, I can speak on behalf of our team, but it's really our team members who are amazing. So thank you, Angel, for this opportunity, and to all of you. But really, it's the physicians and nurse practitioners and nurses and PAs and staff members in the trenches who do this hour in and hour out, who deserve all the credit, and the patients and caregivers themselves, who are the real heroes who go through this. So I'm happy to take any questions. I hope that was an okay overview about what we do and why we're so passionate about it. I'm happy to delve into any of the science or research or anything else I can answer.
Absolutely. Thank you so much. Wow, that is some amazing stuff that you guys are doing over there. That was more than I expected. I don't know how anyone else feels, but that is just some really very cool stuff. And your patient focus being the priority is so important to everyone in this room. The fact that you really do resonate with that and want to see patients in a week's time, and you understand that we have anxieties and we don't want a 2-month wait list to get a follow-up, on what our MRI results were. It's just so valuable that you recognize the importance of paying attention to each and every one of us. So just thank you for all of that. That was so amazing. So yes, we do have questions for you today, and we'll jump right into that. We do have a few of the companions in the room who had a little bit of something they wanted to ask you. So I'm going to start today with John.
Hi, doctor. Thank you so much for that excellent presentation. And I want to go back 2 years now and get a second opinion from you guys.
You're doing well. Nice to meet you, John.
Good to meet you too. And can I ask, this is not my question, but do you know, I was in Madison, Wisconsin, Mustafa Baskaya. Do you know him?
Oh, very, very well. Yeah, we're twins on the follicular side.
Yes.
Dr. Baskaya and I, and he's a great surgeon and a great guy. And
fantastic. That makes me feel better that you know him.
Very well. He's
good,
amazing.
good. I'm 25 months post cradiotomy of a 3-centimeter meningioma, grade 2 atypical. I learned of suddenly when I had balance issues and I walked slowly. I had incontinence and some memory issues. I now have a shunt here and a few lingering deficits, including walking, balance, and extreme fatigue, as we all do. My question is, since my surgery, I sleep on my side and my hands fall asleep. My hands and my feet fall asleep. Stick my hand under the pillow, or if I put them, sideways, they fall asleep, and I get this tingling feeling, And I'm wondering, is that a circulation issue? Is it a blood pressure issue? Should I be concerned? Because I have a sleep deficit anyway, and so anything that causes me to sleep more poorly, I'm always concerned about. So I'm wondering if that's something I should be concerned with.
If it comes and goes, well, first of all, it could be from a variety of things. It can be a circulation issue. It could be an electrolyte issue. And then you just want to talk to Dr. Baskaya, make sure your cervical spine's okay, because that could be another cause. It can be positional as well. If it comes and goes and you're not developing any consequences the next day or anything like that, it's probably okay. If you reposition and it goes away, it's probably not of any major concern, but I would probably just check it out with them to make sure it's not anything in your neck or anything like that.
Okay. Thank you.
But you look great. Yeah, you look great for having gone through that. And I could never tell you have a shunt, by the way, even just, on the Zoom call at least. So
you need glasses, doctor.
Thank you, John. Next up is Jill.
Hi, Dr. Zada and Nicole. My name is Jill, and I'm from Los Angeles, and I'm also a Trojan, so fight on. It's very special to me, place to me. So I was diagnosed with a meningioma incidentally in May 2022. My father had a meningioma that grew back, and I have a small meningioma. It's an extra axial enhancing mass along the roof of the sphenoid sinus, and it's 5 by 5 by 15 millimeters. When I had my last MRI, they noticed that I had a few scattered small foci of abnormal flare T2W signal, which are non-specific in appearance, whatever that means. I received a stereotactic radiosurgery in December, and I have another MRI next month. The meningioma is very close to my optic nerve as well. So my question, which you sort of answered, was, has there been any movement in discovering the causes of meningioma? So I'm going to shift a little bit and ask, what are the statistics of meningiomas returning in familial meningioma, if that's a thing? And also, what are there percentages of meningiomas that don't return when there's non-craniotomy radiation involved, radiosurgery?
Yeah, those are great questions. And thank you for sharing that, Jill. It's a pleasure to meet you. And I'm glad you're doing well. I presume you're doing well, and I'm glad you are. Yeah, they can be familial. And it sounds like in your case, there's a direct link there. We think that there are genes that underlie why people get these, but it takes a little bit more in terms of the environmental cues or things during life that will make them grow, if that makes sense. So it's kind of a nature plus nurture issue. You may need to have the underlying genetic issues, but we know that hormones are a really big deal. That's why much more women than men get meningiomas, but meningiomas are very sensitive to estrogen and progesterone. And so one of the first things I tell my women patients who have meningiomas is you got to really think twice about taking any hormonal supplements, especially if you're going through menopause, or if you are taking birth control pills, or, occasionally we see these tumors grow during pregnancy. So we don't understand exactly why people get them. There is a familial genetic link, but it takes more than that as well. So that's something we are actively studying in terms of, as I mentioned, the familial and genetic components. In terms of the second part of that question, a tumor such as yours, which is fortunately it sounds like on the smaller side, which is good news, and it was treated with stereotactic radiosurgery, should do really well. It should do really well. The rates of tumor control over 10 years are about 90%, meaning that it usually doesn't grow over 10 years. And so I think you're going to do great. That's just the data we have for 10 years, but I have patients who are 25, 30 years out from some form of radiosurgery who still have not had any tumor growth and have stable disease. So let's certainly hope that's the case for you. I think you have a really good shot at that. And it's always important to remember as well that that 10 years, even 5 years from now, the therapies that we have, the understanding that we have and abilities to treat these tumors are also evolving very, very rapidly. So I don't know if I answered your question, Jill.
You did. Thank you. That was really helpful.
Excellent.
Perfect. Thank you, Jill. Next up is Elizabeth.
Hi, doctor. I'm a little over 2 years post craniotomy for a meningioma that was on my brainstem. They could not remove it. They only debulked it because they said it was connected to a blood flow, and it was pressing on the brainstem where it was indented. So they had to take the pressure off the brainstem from the meningioma pushing on it. 6 months later, I had a gamma knife to stop it from growing and to help shrink it. At this point, that tumor is fine, but I actually have 4 meningiomas. So the one I'm concerned with, I wanted to add in that after they did the craniotomy, I came down with trigeminal neuralgia, and I lost the hearing to my left ear. What I'm concerned with right now is I have a meningioma in the right side of my head. This is what the MRI stated, that it was a solid enhancing extra-axial mass centered on the right anterior clinoid process. It abuts the supraclinoid carotid artery. It doesn't encase it. It extends into the right cavernous sinus, to the superior orbital fissure, and into the right optic nerve. In 6 months, it grew from 1.7 by 1.6 by 1.4 centimeters to 2.1 by 3.1 and 2.1 centimeters. And that's in a 6 months range. Would you consider that meningioma a stable meningioma or anything to be concerned with?
Thank you for your question, Elizabeth. And the ones by the brainstem that you had treated are often the most challenging ones. And so it often takes, as you mentioned, surgery and some form of gamma knife or radiation. For the one you're talking about near the clinoid process, to be very honest, I'd probably have to see it because the measurements sometimes don't do it justice. And some of you have probably experienced this before. And I'm sorry I can't be definitive about this, but there's many ways to apply measurements to tumors on MRIs, and every MRI is a little different. And you've probably heard this before, but even just the angles that they're taken at and the snapshots can cause the measurements that you're seeing or whoever's doing the measuring to be off by a few millimeters. So A few millimeters are often considered within normal range, depending. So the answer is I'd probably have to see the MRI and look at it myself. There's another way of measuring tumors, which is looking at the volume of it rather than the diameter. And that's a much more accurate way, but it takes some processing from the radiologist to really look at. And sometimes the diameter doesn't change very much, but the volume does. And just going back to geometry for a second, and not to be a total dork here, but the volume is a cube of the diameter. And so the diameter could change just a little, but the volume can change tremendously. And so it really takes a keen set of eyes to measure it properly and to give you the answer that I think you need and deserve. So I'm sorry, I can't tell you for sure. It sounds like it could be within what I call stable, or it could be real growth. And it would really take someone to assess it with a keen eye to give you that answer.
Okay, thank you very much.
Always happy to help if I can, by the way, but
Thank you, Elizabeth. One other question we had with Elizabeth is she had one of her tumors debulked and it was a grade 1. And we were just curious, we were on a Zoom call yesterday. Is it possible to have multiple tumors with different grades, or would you assume if one was a grade 1, they're all grade 1? How does that work?
you can't say for sure. The imaging can give you a cue if they look the same. Sometimes you can say that, but you can't really assume that. They can be, one could be more advanced or had been there longer and have more opportunity to develop into a grade 2 tumor. So we've seen grade 1s in some patient in the same patient. We've seen some that are grade 1 and others that are grade 2. And so you can't say that for sure. It's probably a grade 1, but until someone checks it, you can't say that for sure. And there may never be a reason to check it, by the way. Depending on what your doctor and your plans are, they may never need to get tissue from that other one. And then I'm sure you're having that conversation with them about whether to treat that other one as well.
Mm-hmm. Perfect. Thank you, Elizabeth. I'll go next. My name is Angel. I'm from Los Angeles, California. I had an 8mm meningioma incidental finding back in March of 2013, and fast forward to December 2018, it had grown to 2.1 centimeters, butted up against the main vein, then obviously was a bit more problematic and needed to come out. So it was over my motor cortex. I had 99% of it removed because it had kind of pressed into that main vein. They had to leave some cells behind, but I'm hopeful that it will remain stable and not grow back. I'm good so far, over 4 years now. But I never had deficits going in and didn't have really any deficits post other than obviously fatigue, extreme fatigue, and just general anxiety around this condition. But my question is, one of my regrets looking back is that I kind of wish I'd gotten it out sooner before it became, oh, you need to get this out because it's in a location like that it could be problematic. And my neurologist at the time never really advised me to see a neurosurgeon and said I might have this for 20 or 30 years and that it was small and since I had no symptoms. And so I'm just curious, do you feel that if someone's diagnosed with this condition, even if it is tiny and seems not problematic, do you feel it's important to see a neurosurgeon right away just to get some insight? Or is it really okay to just sit back and watch and wait for years and not be concerned? What are your thoughts?
Yeah, that's a great question. I think it depends on the care setting and the patient as well, especially in terms of, maybe their age or their preferences or whatever else is going on. Sometimes we find really tiny ones in patients who have other diseases. They're getting MRIs for other reasons, and it may not be a priority. In general, if the patient has any anxiety about it, I always recommend a referral to a neurosurgeon. And the reason for that is, I work so closely with our neurology colleagues, but in actuality, neurologists don't treat meningiomas. They can diagnose them or get MRIs, but those decisions are probably best made by someone who treats a neurosurgeon, or at least to counsel patients about their options and talk about alternatives. So as you know, there are many ways to go about a new diagnosis of a brain tumor or meningioma, and decisions between observation, radiosurgery, and surgery are can be very nuanced, and they depend on a lot of things, not just the MRI. age is probably number one, but things like symptoms, other medical conditions, patient preferences are so important now. You know, a lot of patients just don't want radiation for any reason. They have a fear of radiation, or it's just not something they want to do. Other patients don't want brain surgery, and I completely understand that. You know, if they don't need it, or there's alternatives. So I think that counseling is probably better done by a neurosurgeon. I always would recommend it, but again, it depends on where and who and things like that.
Thank you. Yeah, when we talk in our Zoom groups, I definitely encourage people to see neurosurgeons sooner than later, just based on personal experience. But I was just curious your thoughts on that. So thank you.
Yeah, and I have so many patients, countless patients that we're just following tumors. I see them every 6 months or every year. I've known them for, some of them for, you know, up to a decade, and their tumors never grown. And you know, they're obviously in the more fortunate batch. And it doesn't mean their tumors won't grow one day, and that's why we're watching them. But whenever we can get away with not doing anything risky, or that will affect patients' quality of life, and it's safe, then that's a preferred way of going about it.
Agreed. Well, thank you for that. So as many of you know, today is my birthday, and I can't think of a better gift than to be sharing it with you guys and kind of recognizing what some of our collaboration efforts are going to be over the next few months. So one of the reasons that we do this is to bring education to each other and patients in this community. And another reason is to raise funds for research and to do really good work and to move things forward in this arena. And Dr. Zada and Nicole, I'm so proud of everything you guys are doing there. I have, you know, a big heart for USC as well. I worked there for 8 years. We are very much Trojans in this house. So we do this in honor for ourselves. We also do it in honor of a dear friend of ours, Maki, who is a companion, and we lost her recently in February. And she passed away with stage 4 glioblastoma after a 7.5-year fight. She was a huge inspiration to all of us, and her spirit really does live within our community. And so our Brain Tumor Companions this year are very excited to again, raise money and to spread awareness. May Gray is upon us. And so I have my list of things that we're going to be doing, and I want to just share them. And if I look down, it's because I don't want to forget anything. But starting today, we're going to be sharing the USC Brain Tumor Companion Ambassador page. So thank you, Nicole, for helping us to get that launched and ready to go in time for May Gray. We will have a link, we will have a QR code, and the goal is to raise 50,000 or more for your research. We hope we can get there. I just call on anyone who's watching this to reach out to your family, your friends, your colleagues. Never be shy to ask and share, to ask for support and to share your story. This is not a condition we have to fight alone. We get that people don't always understand what we go through, but there are a lot of people out there who would be willing to support and show that they care. So please do spread the good word. Together, we're going to promote May Gray, and we also will be wearing gray, talking more openly about it. I certainly will be doing a lot of things to just get the word out. I plan to create some social media posts for people. Last year, I did the We Are the Faces of May Gray campaign and did a bunch of free social media posts for everybody. And it ended up being a really big hit and took up a ton of my time. I'm happy to do it again this year, but I am going to ask people who want those profile photos to donate $5 or more to this particular cause. So hopefully we can get people excited about it in that way as well. On Saturday, June 3rd, my companion over here, Brenda, who lives in Tucson, Arizona, I'll be flying out to see her. We're going to be hosting a fundraising event at I want to make sure I say it right, the Crooked Tooth Brewery. We did it last year. We're going to do it again this year. Anyone in Tucson or in the area should come out and say hi and hang out with us. We'll be kind of wrapping up our May Gray success at that point, and then also celebrating and honoring June 8th, which is World Brain Tumor Day. So that should be a lot of fun. And then on October 7th, we will kind of wrap up this fundraising effort and also celebrate with a luncheon with USC and have a special event that we can all come together and meet that's open to all of us in this community. And I'll allow Nicole an opportunity to take over and share a little bit about what that is going to look like.
Great. Thank you, Angel. Happy birthday.
Thank you.
Yeah, happy birthday.
It's nice to be here. Nice to meet everyone. I really am excited about this partnership, grateful for your support. And of course, as patients and caregivers, you know, you've had this experience, this firsthand experience, so you know the impacts of, you know, brain tumors. And we really can't thank you enough for your willingness to support the Brain Tumor Center. For this particular initiative, we're going to be supporting the research of the Brain Tumors Center's tissue core. And so Dr. Zada spoke a little bit about that, which is where they're taking the live cells from surgery and keeping them alive. I'm using lay language here, to kind of track and see how these tumors grow, to figure out why they form, where they form, and then also what drugs work best in fighting these tumors and making sure that they don't continue to grow. And so we've really seen some great traction there. As Dr. Zada said, a lot of things are progressing in terms of research and treatment. And so anything we can do to kind of help encourage that research is really beneficial to us. And we really appreciate all of that work that you're going to be doing over the next 5 months. And then at the conclusion of that, as Angel mentioned, we'll be hosting an event on October 7th at the Hilton LA in Culver City, which we understand is a convenient commute from LAX for those of you that will be coming in from out of town. And we're really looking forward to bringing together the companions along with multiple members of our team. We're thinking that Dr. Francis Chow, who Dr. Zada mentioned, is a wonderful neuro-oncologist, future leader for us and the field, as well as Dr. Neiman, who is leading this research for the Brain Tumor Center. He's our scientific director. He wears multiple hats throughout Keck School of Medicine, and we're really fortunate to have him. And so he'll be able to report more on the work of this core and the other research efforts. And so we're really looking forward to having him as well. And so I really appreciate everything that you guys are doing. Anything I can do to support and cheer you on, happy to do. Thank you, Angel. Thank you all of the companions.
Yeah, no, thank you, Nicole. You've been a great support in getting all of this going and pulled together for us. And it is a really exciting time. And I'm looking forward to the next 5 months to make this happen. That pretty much covers the Q&A portion, but I did hopefully want to get a little bit more out of Dr. Zada. I would love to know what you love most about your job, and maybe tell us a little bit about why you chose to be a neurosurgeon.
Oh, well, thank you for the opportunity. Happy birthday. You know, I always wanted to be a doctor, probably since I was in 3rd grade or so. I don't know where it came from. I don't have any, I'm the first college graduate in my family, actually, and my parents were immigrants twice. So I just fell in love with the human body and anatomy, and then the brain and mind. And I had some mentors who were neurosurgeons and doctors and neuroanatomists. And one of the coolest people who influenced my life was a woman named Marianne Diamond. I went to UC Berkeley, and just really briefly, she passed a few years ago, but this is 2 decades ago, when I was a college student, she was in her 70s, and she was really well known because in the 1950s, she was a PhD in neuroscience as a woman, and there were not a lot of women in that environment. And she became famous for studying Albert Einstein's brain when he died. And you know, what an amazing opportunity that is. And I got to take amazing classes with her, and she really changed my life. And then in med school, I decided, after meeting some neurosurgeons and learning what they do, and what amazing, compassionate people they could be, even despite the reputation of being surgeons, but how they had amazing relationships with patients and families. And I knew that was the journey I wanted to go on with my life. So my favorite thing about what I do is the reward of being able to help somebody through a really tough time in their life. And they're not all wins, but we try to have the best record we can. And I think we're doing pretty well. We had a long way to go, of course, but I'd say that the next favorite thing that I love doing is training the younger generation who, trying to leave a legacy in this field that will be permanent or longstanding at least. And so education is so critical for us as well. I think it's the next generation that are going to come up with the cures that for a variety of things. So a lot of potential there.
Awesome. That all gives us really a lot of hope. And I just really appreciate you sharing kind of everything that you're doing over there and why you're so passionate about doing it. It really does mean a lot. At the end of the day, the neurosurgeons are superheroes. We really need you guys. We're the patients and we depend on your expertise. And we really do look up to you to guide us in the right direction because our life is in your hands. So everything you do is so very important, and we really do appreciate you. So unless anyone has anything else that they want to say or share, Sabrina?
So Dr. Zada, thank you. I'm Sabrina from the East Coast. I'm from Virginia. I had a quarter-sized brain tumor removed from the brainstem and cerebellum when I was 10 years ago, when I was 43. So, and I was shunned. And it's behind my ear here. So my question is, I've never heard of a 17 MRI. So what do I get?
Sorry, what was your last question?
So the 17 MRI I've never heard of. So what am I getting when I
What
go?
kind is she getting first? Yeah.
The most common are 1.5 and 3T MRIs. And those are good enough for most things, but we're trying to understand what else we can do with the power of a 7T MRI. It's not needed currently for routine care, but we're exploring its potential for predicting the grades of tumors, and it gives us some better resolution for trying to find little things like nerves and blood vessels before planning a surgery. So we know where those are located relative to the tumor. So we're getting a lot of new information, and we're still trying to figure out how we can put it to use and help people, but it sounds like a pretty powerful tool currently. So but don't feel like you're missing out right now.
I was just curious.
Yeah.
So I do have one more question. And my tumor was, my neurosurgeon, loved my neurosurgeon, Dr. Alagala. And he took it out. It was benign, grade 2. I don't know about the atypical stuff. Don't know. But so I know like with like breast cancers and other cancers, you have like a 10-year or 7-year period where they say if it doesn't come back by then, you're cured. Is that with brain tumors?
Unfortunately not. The longer you go, the less likelihood that something will grow back. But I've seen tumors unfortunately recur beyond 10 years, 13, 15 years. So no one's out of the woods once you have a brain tumor. And, with something benign, they can be cured, and a meningioma can be cured. Some of the benign stuff can be cured, but more often than not, even after 10 years, we'd recommend imaging every couple of years just to make sure. I've seen all sorts of things, it's a statistics picture, and most people will do well, but a certain very small percentage will have delayed recurrences or progression.
Yeah, thank you. Thank you, Sabrina. John, you have your hand up?
I do. Doctor, this is a little tongue-in-cheek, but not really. I'm a fundraiser for a university in the Midwest. And I'm just curious, when it says the Keck USC hospital, I'm curious to know, what do you know about the Kecks, and what did they give to get their name on the USC hospital?
Yeah, the Keck family, you've probably seen, they've donated widely to a variety of schools, not just us. There's a variety of Keck programs out there. It's the WM Keck Foundation, and I don't know how much they donated. I probably knew that at one point, like 10 or 15 years ago, but I'd probably misquote it, John, if I tried now. It's probably public if you were to Google it. But I can't remember, to be honest. It's you know, it's in the tens up to probably $100 million range, is my guess.
Lots.
Yeah, to name the whole school, but
Yeah.
there's obviously naming programs for smaller programs and centers that are not in that range as well.
Sure.
But thank you for everything you.
Are they still with us? Are they still?
Some of them are. The son is around, and he still heads up the foundation. But I think the original Keck goes back like 100 years or something.
Oh, okay.
There's a Keck observatory that goes back. There's all kinds of stuff, but yeah, I can't remember all the details, but I don't think the original Keck's around now.
Yeah.
The
Thank
son
you,
is
Jen.
still active on our board for the hospital, so they're still very involved. I think it was 150 million initially.
Wow. We need people like that. That's amazing. Lori, you have a quick question?
Yes, I have a quick question. I'm Lori Murtis. I live in Fairbanks, Alaska, and I have a meningioma on my left frontal lobe. And I just wanted to know, I've been taking aromatase inhibitors for my breast cancer because it was ER and PR positive. And like, you know, that's supposed to all go away, but my meningioma grew. So why?
I was hoping you were going to tell me it shrunk, Lori.
Did not.
Yeah, you know, even when we're armed with that knowledge that these tumors have progesterone and estrogen receptors, and that, you know, that finding goes back like 30 years, and people have tried a variety of inhibitors, and the reason we don't use them routinely is because for some reason, even with that knowledge, they don't seem to work. There's a cool study coming out that I got a chance to review for the Journal of Neurosurgery. I'm on the editorial board for them, and it may interest a lot of you. It's from Paris, from my colleague Sebastian Froelich. It'll be coming out in the next few months, but they showed a study about a certain type of meningioma. They were able to treat medically and shrunk with some inhibitors. But I'm sorry to hear about yours. When it's you, all the data goes out the window, doesn't it? Yeah, I don't know what to say about that, but we're not there yet.
Do you have time for one more question, Dr.
Yeah,
Zada?
absolutely.
Okay,
Absolutely.
Pauline. You've generated a lot of thoughts in the group today, so we're rolling with it. Pauline?
Hi, Doctor. I'm from Buckeye, Arizona. My first meeting was 2010 of June. In 2019, with the MRI check, they did find 2 more. I suffer from vertigo and migraines a lot. Vertigo is tremendous, and I just want to get some advice from you as far as vertigo.
Yeah, Pauline, it was breaking up a little. What I heard is you had, I believe, a craniotomy in 2010, and was it a meningioma? And they found 2 others. Is that right, or did I miss some of that? And you're having vertigo now? Is that 2019.
And I do vision therapy.
Okay, it's a little hard to hear.
We can't hear you, Pauline. I'm not sure what's going on with your connection, but it's really choppy.
Maybe turn the video off and the audio might get better. But from what I heard, vertigo can be a challenging one, and it's a tough one if you're suffering from vertigo, because no one likes that feeling. You probably want to see an ENT surgeon if you haven't, not necessarily per se. Yeah, you have. There are some medications that people will try sometimes. They're effective in some people, but not others. Antivert is the name of it, or meclizine, but yeah, the ENTs are probably the best at treating vertigo, and it could be a tricky one. So I definitely, I hear you, Pauline. I don't have a great answer for you.
Thank you. Sandra?
Hello, I'm Sandra. I live in Montebello, California, not too far from the USC campus. And I have to say, you guys are doing a great job. I'm a registered nurse, and I have a lot of great colleagues that work in that campus. I actually have a great friend who works at the neuro ICU there.
Oh, cool.
But anyways, my story is I have history of neurofibromatosis and of type 1. I've had history of other tumors. And over the years, just listening to what you said about hormones and birth control. I've always questioned that to, my primary doctor because of the history of neurofibromatosis about if I could take that, because I've from what I've read that the tumors could grow due to the birth control. And even back then when I was pregnant for my younger son in 2007, after he was born, I was found to have a large tumor in my T1, T2 nerve. And we think it grew during the time that I was pregnant because of the growth hormones. Anyways, last year I wasn't feeling well. I was having problems with fibroids, and I told my and I was having some hearing loss as well. And I told my primary that I wanted an MRI. So we did it, and they did find a meningioma. It's let me get the description really quick. It's not that large. It's 9 by 5 by 4 millimeters, and it's in the left temporal lobe. And I had an MRI back in maybe 10 years ago. So we don't know if it grew in between. But my question to you is, why are other physicians not aware that if you do have some type of history, those meningiomas could grow from hormones or from birth control?
Yeah, it's a great question. And first of all, thank you for everything you do for patients. It sounds like you're doing it all. You're a parent and a healthcare provider and have an F1. I mean, that's amazing. The information is not widely disseminated. I find that a lot of people don't know that for whatever reason, and we don't know how that interplays with if you have neurofibromatosis 1 either. If those tumors are more or less susceptible to the hormonal input. Yeah, I find that a lot of people just don't know that information with meningiomas. So that's why we need a community like all of you. And thank you. I know none of you need to be here today, but you're doing all this out of the goodwill of your hearts and everything you have going on. But yeah, we need to disseminate that information, right? That and maybe a time to revisit it scientifically too. But a lot of providers, and I always ask again my women patients to go back and talk to their OB-GYNs and endocrinologists about these issues because it's a two-sided story, right? A lot of people have to take other medications, as I believe it was Lori who mentioned that she had to take some of these for other reasons, and so there's a lot of interplay there. But your points are very well made, Sandra.
Thank you, Sandra. Thank you, everybody. And Dr. Zada, I really appreciate you taking a couple more questions than maybe we had planned for. Super excited to have you here today. Really looking forward to celebrating May Gray and fundraising for all of you. It's just an exciting time of year for all of us to spread awareness. And I just thank you all for being here. And if you have any patients you want to send my way, know that we are a safe place to fall for them. It's a beautiful community where we just kind of hang out for 90 minutes, sometimes 2 hours. We let it all out. We vent, laugh, cry. We celebrate the wins when those MRIs are clear. And it's really just an opportunity for everyone to feel a sense of community in a rather kind of alone time of our lives, which seems to just last and linger in some way. As you mentioned earlier, we're like forever a brain tumor patient, and it doesn't really go away once we're diagnosed. So that's that. That's a wrap, everybody. So appreciate your time on this beautiful Friday on my birthday. Love each and every one of you. And I'm going to see you guys in October, Dr. Zada and Nicole. I'm so excited.
We're looking forward. Thank you for having us, Angel. Nice to meet you all. And
thank you for your time.
Happy birthday.
Thank you very much.
Thank you all
so much.
Thank you.
Take care. Thank you for the great work you're doing.
Thank you.
Bye.
Bye, everybody.
Bye.
Bye.